welcome everybody. We're going to go ahead and get started, and I have the privilege to introduce Dr. James Lenhard. He's going to talk about diabetes and stroke. So just a little bit about Dr. Lenhard. He has a Bachelor of Science from Cornell University and Doctor of Medicine from Albany Medical College. He does internship and residency in internal medicine at the Miriam Hospital of Brown University, fellowship in endocrinology and metabolism at Harvard Brigham and Women's Hospital and the Beth Israel Hospital, and he currently serves as the Section Chief of Endocrinology and Metabolism at Christiana Care Health System, Medical Director for Metabolic Health Services, and the Director of the Diabetes and Metabolic Research Center. So welcome, Dr. Lenhard.
Thank you. Thank you for the introduction. Thanks for inviting me back. It's been about a decade since I presented at your symposium today. This is an update on diabetes and stroke, and you know that they go together. In terms of disclosures, I have an off-label mention of an old-fashioned diabetes drug that's generic now. And in terms of the content, we'll go over quickly some up-to-date diabetes data, a mention of the metabolic syndrome, which I'm sure you're familiar with, the link between diabetes and stroke, and most of the talk will be on preventing stroke and cardiovascular disease with medications, particularly diabetes medications. Just a quick update on diabetes. You know that it's a very common disorder. You see it every day, and you know that there's a link with stroke. You may not be aware of quite how prevalent the numbers have become. In the year 2014, the CDC predicted that if you have a child, a niece, a nephew, a neighbor that was born in the year 2000, they had a 2 out of 5 chance of getting diabetes in their lifetime. Unfortunately, this number seems to be low. Diabetes and obesity track together. And we know that America as a country is getting wider. And diabetes follows right behind it. If you, let's see if my mouse works here. Oops. If you look at the maps, the diabetes tracks behind obesity by about 5 years or so. So as America gets wider, the map gets redder for diabetes as well. Now, if you look at the prevalence of diabetes and look at 2011 estimates, we were looking at about 19 million Americans and 7 million that were undiagnosed for a total of 25.8 million, and another 79 million that were waiting on deck with what we call pre-diabetes, 8.3% of our population. And then just 1 year later, in 2012, we're already up to 29 million with 86 million waiting on deck. So the news is bad, but it's not all bad. It's actually showing signs of leveling off lately. So if you look back over 50 years, it's a really steep upwards trend. But if you look back just over the last couple years, the CDC is actually finding that it's leveling off or maybe even dropping a little bit. The annual number of new diabetes cases from 2009 to 2014 actually dropped. So some of our initiatives may be having some success. Now, if you compare that to back here in 1980, when it was less than 500,000 new cases of diabetes, it still is a big, dramatic increase. But the report that I think carries a lot of weight was published about a year ago, and it looked at the prevalence based on something called NHANES data, National Health and Nutrition Examination Survey. So this is not phone-based or record-based. This is an actual examination of patients. Now, that's time and money intensive, so you can't do it on everyone in the country, but it gives you real data. And in this study, they looked at the prevalence of diabetes and prediabetes using some standard techniques, hemoglobin A1C, fasting glucose, and 2-hour postprandial glucose. And then you'll see that they did some fancy statistics with adjusted and unadjusted. If you adjust for age and look at the total number of cases of diabetes, it's rising, like we said. And the rise seems to be from diagnosed diabetes. And undiagnosed diabetes, while still common, is not getting any more common. So the rise is from people that have it, and we know they have it. But if you combine diabetes of 12.4% and pre-diabetes of 38%, you're talking in the year 2015, 1/2 of the American adults that have diabetes or pre-diabetes. And we know people that have pre-diabetes convert to diabetes at a rate of 5 to 10% per year, meaning that if nothing is done, in 10 to 20 years, the majority of people with pre-diabetes will have advanced. So that initial prevalence prediction of 40% looks to be on the low side already, just today in 2015. So I wanted to see what the numbers would be here in Delaware and in the U.S. So I went to the U.S. Census website, and it's as dry as you might think it is. And I looked at the population in Delaware of adults age 20 and older, and using these prevalence data, the number of people with diabetes, not pre-diabetes, just diabetes, is 100,000 in Delaware right now. And in the U.S., I got the exact same number that the CDC got, 29 million. Now, this report came out with an editorial that said that there is some room for optimism. As I pointed out, we've had a leveling off over the last few years, and there seems to be some shifts in cultural attitudes towards obesity. It's being recognized as a disease state and not a failure on the part of somebody that is weak and unable to put down the fork. So we've had some plateauing of obesity and diabetes, and also of the metabolic syndrome, as we're about to see. Now, I hope you're familiar with the metabolic syndrome. It's very much obesity related. So any three components are what's needed for the metabolic syndrome. These are the United States levels of waist circumference. The World Health Organization lets the U.S. have the biggest waist on the planet. Other countries, other cultural groups have a lower threshold to qualify for the metabolic syndrome. And abnormalities in lipids, blood pressure, or fasting glucose would also qualify for the metabolic syndrome. So obesity is an inflammatory condition. There's no question about that. And in recent years, it's become very well known that fat is actually a hormone-producing tissue. It makes a lot of hormones. And a whole bunch of the ones that it makes are atherogenic. Adiponectin is said to be anti-atherogenic. That may not be entirely true. At low levels, it may be neutral and not protective at all, and some reports intriguingly suggest that at low levels it's actually atherogenic, and at high levels it's anti-atherogenic. But this is the important side over here. Your fat makes a whole bunch of hormones that predispose to cardiovascular disease. Now, if you look at the prevalence of the metabolic syndrome, this is the latest data I could find, and if you look at people aged 20 to 40, you're talking about a fifth of Americans. And more middle-aged, 40 to 50, you're a third. And if you look above 60, it's just shy of 50% of Americans that have the metabolic syndrome. Whole bunch. But we've seen some improvement here too. The metabolic syndrome has stabilized and actually declined a little bit in women recently. And the only explanation for this is the improvement in obesity in America, because all of this is driven primarily by obesity. We have people immigrating and new genes and new medical conditions, but all of that pales in comparison to the problem that we have with obesity. So here's some more good news. This is trends in diabetes-related complications over 20 years. And the two we're looking at in particular today are atherosclerosis, heart attack and stroke. And it's not just a decrease, it's a dramatic decrease by more than a half. of people that have diabetes and atherosclerosis, making some real progress. And this is almost certainly from better medicines, earlier and more aggressive treatment, better medical advances. We're also making advancement in the prevalence of diabetes with amputation and kidney failure and death from hyperglycemia. So diabetes and stroke go together, just like diabetes and heart attack go together. The vast majority of strokes that occur in people with diabetes occur in people with type 2. But if you're going to have a catastrophic stroke, something that occurs at a dramatically young age of 15 to 34, it happens in people with type 1 diabetes. And I'm guessing all of you can picture someone like that. I've got at least 5 people in my head right now that are dramatically young and have had their life forever altered by a catastrophic stroke at a very young age. If you look at a follow-up study of people with type 2 diabetes, and it was pretty big, 13,000 people, having diabetes increased the risk of stroke twofold in men, but 6.5-fold in women. Not clear why it's such a bigger risk for women than it is for men. And it turns out that whatever glucose you're admitted to the hospital with when you have a stroke makes a big difference. If you come into the hospital with a stroke and your glucose is above 200, you've got twice the risk of 30-day mortality than if you have a glucose below 200. So there's no question that the risk of hyperglycemia at the time of a stroke, or a heart attack for that matter, increases your risk of mortality. What's not clear is whether glucose lowering in the long run helps to prevent a stroke or a heart attack itself. And that's what the rest of this talk will be about. Now, this is kind of busy. I'll walk you through this. Some of you may remember a medication called rosiglitazone, or Avandia. And there were a series of articles that came out saying that this drug not only does not prevent heart attacks, it causes it. And in subsequent studies over the next decade, it turned out that that was not the case. It does not cause heart attacks. But the FDA got egg on its face. They looked bad, and they said, this can never happen again. And they instituted a new policy, and that was that any diabetes medication after Avandia had to perform what's known as a cardiovascular outcome trial. They didn't want any more diabetes drugs causing heart attacks, even though it really didn't. So you can see that a whole bunch of people are now enrolled or have completed cardiovascular outcome trials. And these are the newer drugs that we're looking at here. The older ones weren't forced to do that. So some of them have reported already with the red check marks. Saxagliptin or Januvia, alogliptin, sitagliptin, and they've already reported, and they were neutral. These drugs do not cause heart attacks, and they don't prevent heart attacks. And these are big studies, like we talked about, and they were fairly long. You could argue not long enough, but they did not cause or prevent heart attacks. And then in the fall of 2015, September of last year, a medication called empagliflozin, sold as Jardiance, presented their data at the European meetings, the European diabetes meetings, and it floored us. It knocked us over around the whole world because their drug actually decreased heart attacks after all of these drugs that were neutral. And then 2 others have reported as well, liraglutide, sold as Victoza, and semaglutide, which is not yet FDA approved, and in circles here, these 3 have shown the same finding as empagliflozin, that they have decreased a heart attack, and that's what we're going to talk a little bit more about. And then you can see a whole bunch here that have not reported yet. So the first one, the dramatic one, was a study called EMPA-REG, looking at empagliflozin. So this was a randomized trial of this medication, 10 or 25 milligrams versus placebo, and people were obese and they had reasonably good kidneys, and they had a hemoglobin A1C between 7 and 10. And investigators were told to treat other cardiovascular risk factors to get the best possible outcome. 7,000 patients followed for 3 years. The majority, 70%, 70-something percent, were on metformin, or about half on sulfonylurea and half on insulin. And then a handful were on these other medications. Now, these patients were treated aggressively. If you look at the number that were on antihypertensive therapy, most of this were ACE or ARBs, 95%. Statins, 80%. Aspirin or antiplatelet drugs, 90%. Aggressively treated with state-of-the-art therapy.